So let me welcome everybody to our nuclear engineering graduate colloquium program. I'm Dr. Wes Hines. I'm the nuclear engineering department head. And we're very lucky today to have Dr. George L. Fakhri, who's the Nathaniel and Diana Alpert Professor of Radiology at Harvard Medical School. He's also the founding director of the Endowed Gordon Center for Medical Imaging at the Massachusetts General Hospital and Harvard Medical School. George is also co-director of the Division of Nuclear Medicine and Molecular Imaging and a faculty member of the Harvard MIT Health Sciences and Technology. Dr. L. Fakhri is an internationally recognized expert in quantitative molecular imaging for in vivo assessment of patho-physiology in brain, cardiac, and oncologic issues. Current areas of research include high-resolution PET-MR imaging in a range of diseases, including neurodegenerative disease and traumatic brain injury, cardiac disease, as well as guiding radiotherapy planning. He has co-authored or authored over 300 papers and mentored over 100 students, postdocs, and faculty. He has received many awards and honors, including the Mark Tettleman Award from the Society of Nuclear Medicine and the Dana Foundation Brain and Immunoimaging Award, as well as significant funding from many NIH institutes. He was elected fellow to the American Association of Physics and Medicine, the Society of Nuclear Medicine and Molecular Imaging, the American Institute for Medical and Biomedical Engineering, the International Academy of Medical and Biomedical Engineering, and the IEEE for his contributions to quantitative biological imaging. So if you weren't good at counting there, he is a fellow of 5 different professional societies. I don't think I've ever introduced someone that's fellow of 5 societies. That lets you know a little bit about his impact on the nation, which is just fabulous. So welcome to our graduate seminar.
Thank you for the very thoughtful introduction. I wish my parents were on the talk on this. Probably my mom would be happy and my dad would believe every word you said. So thank you. Very thoughtful introduction. It's a pleasure to be here. And it's a great pleasure to meet some of Jason's colleagues, because Jason and I have worked together on at IEEE and some on meetings, and I got to know him as a great colleague. So it's a pleasure, and I have tried to in my talk to put in what Jason had asked as the things that you'd be interested in. I hope this corresponds to what you're looking for, but we can have questions at the end if there are any questions on any piece, or if there are other pieces you'd like us to cover. I have some slides also put aside for based on some questions that came ahead of the talk, which again is a rare thing. Usually I never get questions before the talk. This is really a good sign of engagement. I just want to make sure everybody sees the full screen, because I see both and I want to make sure you see the right one. Is that okay?
It looks good.
Okay, sounds good. So I wanted to start with a little bit of history. And the reason is because the very beginning of PET started to guide radiotherapy, which is what you folks are interested in. So it's ironic that from the beginning, the way people invented PET was for that. So the very first PET scanner actually was a PET imager. It wasn't a full scanner yet. Was developed by the person who ran the center that I run today about in 1954, before I was 52, before I was born. So Gordon Brownell developed a set of 2 detectors. He was a professor at MIT who was also the physicist at Mass General, to look at coincidences of positrons that would annihilate inside the body. And that's Gordon Brownell. And the very first application was by Bill Sweet, who was a neurosurgeon at MGH, who had approached Gordon and said, you know, I would really like to make sure that I'm operating on the correct side of the brain when I have to do these neurosurgeries to extract tumors, because sometimes we're not sure we're taking everything out. I want to make sure I'm the right side, on the correct side, and I'm taking everything out. Do you have anything that can help me with that? And Gordon said, well, you know, I have this system I'm building up, but it's not completely ready yet, but I can bring it over from MIT, and we have a cyclotron there. I can generate some radioactivity for you. It was arsenic at the time. And we can inject somebody if you have somebody, and we can image it. And no RVs, no FDA, none of that. And remember, this is 52. And in 53, so within a year from the time he built that first prototype, they had scanned the first patient. You could get a sense of how long it would take today if we're developing a new modality and then going to the FDA to get approval and then doing the first patients. And this is the very first scan that was performed, and we could see that they looked at the coincidences on the left side and the right side of the brain, and that could confirm that it was on the right side, that there was on the left side, sorry, because right, left, that there was an excess of activity. So that's where the brain tumor was. And if you note here, this artistic drawing, this is the anatomical imaging that was done at the time by the neurosurgeon to know where they were in terms of the brain based on where they were scanning. So the very first scans were with the idea of looking at therapy. And then the second piece of that is also the tomography part, because you had to then figure out where things are going if you're not going to draw something with your hand. And the very first filter back projection developed for PET was also done by Dave Chesler in the same center. So that was 1972. So I think for you guys know exactly what positron emission tomography is, so I won't spend too much time on that. I will just say that what we are doing clinically is injecting a radionuclide that is an emitter of positrons that are going to emit also neutrinos, but the neutrinos we don't care for, we can't see them anyway. All we care for is the positron. That positron is going to annihilate very quickly in the body by when they meet an electron, and from that annihilation, we're going to have from having that antimatter meeting with matter, we're going to have an annihilation with 2 photons emitted. Those 2 photons are always emitted at 180 degrees. Well, we'll assume. I know this is a engineering and physics department. It's not exactly 180 degrees, but we're going to assume it's 180 degrees for this talk anyway. And all what we do is detect those in coincidence. I thought I would start also by giving you a very quick overview of who we are. So you get a sense of, in case you want to collaborate with somebody in our center, you know who we are. So the Gordon Center is actually a center that is dedicated to improving patient care by using imaging. So we want to use imaging to better understand pathophysiology and better take care of patients. So our final application is always, and our final destination is always in patients. We are a little more than 142 patient members now. We're about 160. And this is, as I said earlier, the continuation of the Radiological Science Center, which in the 50s is where PET started. We do everything from cell culture to mice, rats, rabbits, for those who don't know, woodchucks, very good liver cancer model, sheep, pigs, non-human primates, and of course humans. And we do about 1,300 human studies a year for research studies. These are all research studies. None of those are clinically reimbursed or clinically prescribed. And we have about 22 radiopharmaceuticals used on any given week. Distinct pharmaceuticals that are being used. We have about now 18 INDs and 2 ANDAs with the FDA. And we serve a large group of users. The users are not only in radiation oncology or radiology, they're also in medicine, psychiatry, anesthesia, endocrinology, etc. And these are the labs who are in our centers. So put some names in front of who's doing what. And you see that the range is quite wide, from some in the basic instrumentation engineering, some more on the clinical spectrum application, clinical trials in aging and in cardiac disease, and everything in the middle, radiochemistry, cyclotron, tomographic reconstruction, pulse design in MR, pharmacokinetics, pharmacodynamics, proton therapy, which I think is of interest to some of you, brain networks in aging, you name it, it's there. So I wanted to start first with one application based on some of the questions that Jason had brought up when we talked, which was about how can PET be used to guide therapy. And the example I'm going to use is going to be in sarcomas. This is an interesting case because sarcomas are a very tricky tumor for treatment. And one of the big challenges when we use imaging for treatment is that we would like to determine exactly what is the tumor, because usually we have a very good, very accurate way of targeting where we want in the space, in the 3D space, so anywhere in the patient, especially when we're doing proton. And the second part of my talk will be dedicated to that. But the difficulty is not to be able to target exactly a given location. The difficulty is to know where is the location we should target. So that's what we call the gross target volume. Basically, what is the tumor, gross tumor volume? What's the tumors, where is the tumor that we should be treating? And in soft tissue sarcomas, there is a consensus of the ARTOG regarding these tumors that is quite harsh. It's about 3.5 centimeters longitudinally that you would have to take around the tumor and 1.5 centimeter radially. So, so this is quite a bit. Maybe I can show you here in a better example. So if this was a sarcoma, this is what I would treat. And you see that this is quite a bit of a volume. So the questions we're asking here, and actually that the radiation oncologists were asking us, are the following. One, could you help us figure out if this is really needed, or could we treat less than that? This is a lot. Two, when we treat, usually what happens is the tumor is, there's surgery afterwards, and then, there's debulking and then radiation therapy, and then we're done. But the problem is that when you do that surgery afterwards, you're taking a substantial amount of muscle in the surgery. So that means that there is physiotherapy that has to take place for months afterwards. Usually, typically, it's about 60 to at least 60 days, and in general, 6 months before somebody can walk again, if it's a tumor like the one I'm just showing here. So about 20% of the patients will decline surgery, will say, I'll have radiation therapy, but no surgery. No, thank you. I need to go back to work. I can't afford a year in physiotherapy. And in that case, about 20% of those who decide not to go for surgery will have recurrence. So the second question we were asked is, could you tell us ahead of time, or when you treat, or right after you treat, or where are the areas that have we treated everything? Or are there any areas we haven't covered? Or are there areas that are surviving? And those are all very valid questions. You want to try to use imaging to guide that treatment. So that's the first angle I would like to present to you in terms of image-guided therapy. How can we use the imaging to provide the best treatment possible? So here's an example of how this would work. Here's a patient that comes in with, this is the pre-radiotherapy MR that you see here, T2-weighted MR, and here's the PET. Based on MR, all of this is enhancing would be treated. And this is what usually the ARTOG would do, right? So the question is, can we treat less? Well, based on PET, you would see, and in this case, PET is fluorodeoxyglucose. So it's a sugar that is, tumors are anaerobic metabolism, so they're avid, most of them are avid for glucose. So I would say, well, this is the area you should concentrate on. Now, if this was my grandmother and they told me, okay, well, are you okay with just treating that and not treating anything else? I would say, well, I don't know, maybe we should treat everything just to be safe. So you're going to have to prove to people that this is enough to treat. And the way to do it is to treat, extract the tumor, and then look at the pathology. And that's what we will be doing in the next couple of slides. Here's just a teaser of that. So you see here that here's and I apologize for those who are having lunch. I haven't had lunch, but if you're having lunch, you can skip over this image if you don't, if it's bothering you. But you can see that in this area here, we have a clear correspondence in the appearance of the tumor with this area, which is the hotter area, and that was confirmed by pathology that this was actually the area with the highest mitotic rate and tumor growth, and the rest was actually not tumoral. So this is this answers the question, yes, actually you could treat less if you had imaging ahead of time, and if PET would tell you with MR the smaller area of real tumor as opposed to edema that you would need to treat. Remember, the second question was, well, could you also tell me if I missed anything, or is there any area that has survived? And the answer to that is also yes. So here's a case where after treatment now, there's no more uptake in the tumor. Remember, this was this. Now there's no more uptake, but there is this little uptake in this on this rim of activity on the distal side of the tumor that is still a little suspicious. And the question is, what is this? Is this tumor that has remained, or is this simply inflammation? After treatment, after radiotherapy, you're going to have a lot of inflammation. So it is not uncommon to see some uptake. And I think that answers part of that, one of the questions that were asked. It is not uncommon that you would have inflammation. So in order to differentiate those two, those would also be glucose avid. So in order to differentiate those two, the idea would be to do spectroscopy. So spectroscopy is one solution. And why? Because in this case, you know where to look. And I know that in that question, one of your colleagues had said that, your medical colleagues are not very keen on doing spectroscopy. There are very good reasons for that, because usually you don't know where to look, and you can't just go and look at every location where you have a tumor and do an MR spectroscopy, position the box everywhere. It's very time consuming. But if you had a way of knowing where to look from PET, things would be a lot easier. So in this case, this is the side that we treated. The right side was treated, the left side was not treated. And this is where we have questions now on PET. Remember, on MR, there's nothing here that is a sign of suspicion of anything. It's impossible to tell if there's anything recurrent or not, or surviving here on MR. On PET, we have a signal here, and we don't know what that is, but we know where to look. So if I look at MR spectroscopy now, where I have a hot signal on PET, then I could see that the choline to creatinine ratio, which are two proteins I'm looking for, the ratio is normal compared to, for example, the contralateral side where there was no tumor. And that ratio is very much the same. Whereas if I looked at the area where the tumor was, just for a sanity check, the choline to creatinine ratio was much higher. It was double. So that tells me this is most likely not tumor. This is just inflammation. And sure enough, the patient came back 3 months later, and there was nothing left there. So this is a very nice scheme to tell, well, what is tumor and what is inflammation post-treatment to decide whether or not we have treated all the tumor, or during treatment to decide whether or not we're seeing pseudo-inflammation, pseudo-progression, or we're looking at actual progression. But in order to do this, what I showed you here, and I said, well, look, those are perfectly registered, and you can see this tumor here is right here. I skipped many steps. The first one is, once you resect the tumor from the patient, that tumor is going to collapse. It's going to be mushy, it's going to collapse. If you ever saw any of them, these tumors, they look like burned meat, so burned fat, actually. So you're not going to be able to compare to the MR or the PET acquired in the patient, let alone to retrace exactly one location on the image to a location on pathology. So the way we have gotten around that to be able to do that is we devised a pipeline where we do the following. So we first do an MR where we delineate exactly where the tumor is. Then we do a 3D printing of the tumor environment, meaning what is surrounding the tumor, as well as the tumor. And actually in here, you see this is like a locket that you can open, and then the tumor comes up and then it comes back in. The second thing we do is, so this is now ready like a cradle for the tumor. The second thing we'll do is we'll have some ink on the bottom side, all along the side before the tumor comes in. Now, when the tumor comes in, what we do is, as soon as the tumor is extracted, it's put in here, and then it's frozen. And then you can do sections that are very thin without deforming the tumor. So now we have something that looks like this. And again, I apologize if anybody is eating lunch while watching this talk. And you can see here that this side, for example, this looks like good meat. This is what you would, this is what you would be grilling on your barbecue. This is not the kind of thing you would be at all interested in. This is tumor actually that has been treated, that is necrotic. Sorry. So now I can relate each of those sections to my scan, because those were acquired in the same, they're angulated on the same angle. They're perfectly registered. I acquired the cradle where the tumor is exactly what I acquired the image before. I've sliced those in the same direction. I've registered them. And now I can have literally my pathology slides. And those are the pathology vignettes that you're seeing, which are what the pathologist looks under the microscope for each piece of tissue that we're taking. Usually it would take about 3 or 4. We're taking about 30 because we want to cover the whole tumor. And I have those two registered perfectly. So now I have my imaging and my pathology perfectly registered. And I can look at where do I see uptake and what does that correspond to in terms of pathology. And that's very important, because if you don't have a perfect registration, there's nothing you can say about correlations between pathology and imaging, in vivo imaging. So what can you do with this? Well, now that we have that, we could look at, on the pathology side, all sort of parameters that are standard. The mitotic score is 1, percentage of tumor cells, those are counted, percentage of necrotic cells, the MIB1, the proliferation index for staining. And on the imaging side, I could look at the T1, the T2, the SUV on PET, choline to creatinine ratio from MRSI, from MR spectroscopy imaging, where I can do the whole image. And I'll show you an example of that later. And I could correlate those two. A better way of doing it is going the deep learning route, because this is a perfect example of where you can do a meaningful learning, where you have the entire data, you have the gold standard, you have the truth, and you have enough samples that you have enough data to learn what looks like what. So the input here would be your MR and your PET, the output would be your pathology. And the way we do it is register the pathology patches, slices with the PET MR patches, and then you do an automatic detection and classification of these cells, so that you'd see these are what look like tumor cells, these are normal cells, and then you have that overlaid with your PET. The way we do this in terms of classification is not creative at all. On the contrary, we decided to go with what is used clinically to classify the tumors. So what we decided to do is to go with the Fédération Nationale des Sarcomes. It's the French society that has defined the sarcoma rankings and characterization. And based on these, we define if a tumor is necrotic, mitotic, etc., and enter those as labels in our deep learning. Very simple. So that allows you then to have a 2-level enhanced target volume that you can use in your treatment planning. And we'll see in an image how we do that in terms of treatment planning. But there's another value in doing MR spectroscopy and PET in addition to MR or CT, and that is that a lot of times we detect lesions and tumors that are distant from where we are doing our treatment plan. And those you would never see otherwise. So here's an example in another sarcoma. We're looking at the treatment plan. This is the CT treatment plan that the radiation oncologist had decided to draw. And this is the T2MR. And okay, this one is a little better, but it delineates about the same area. Except that when we looked on PET for the same patient, we realized there was another tumor here that was not at all visible on CT or on MR. And this delineates a key contribution of what you can get from PET or from MRSI. Actually, on MR spectroscopy, you could see also part of that. And that is that there is no point in having a proton beam and being accurate to the millimeter in delivering the dose if you're not delivering dose to the tumor, if you miss part of the tumor. Because yes, you would deliver faithfully and reliably a dose here, but you would miss this tumor and then there will be recurrence. So I think that's a very good way of illustrating the value of using imaging to guide therapy as opposed to treating only what you see on CT. So now the next part of of this first part of the talk is to look at how can we now delineate or help delineate the gross tumor volume. So if I have that information now, how can I delineate where the tumor is? Because this is a very tedious task that usually a radiation oncologist has to do. And there are many limitations to that. One, at all levels. If you're in a tertiary center or a referral center that is doing a lot of those, you're going to have studies that require a lot of time that a radiation oncologist is supposed to do. If you're in the totally opposite setting, think of many sites in Asia where you have a lot more instruments than you have physicians, and where the physician doesn't have enough time to train on specific tumors for delineation. So it would be nice in that case also to give an initial starting point of where you think the tumor is, that they can confirm or infirm. In both cases, you're saving them a lot of time and you're avoiding gross errors. So the idea is here we would like to use machine learning to improve the gross target delineation, and more importantly, provide something that will be comparably variable with what you'd have between two physicians. Meaning, what we want to give is something that will be no more variable, no more different than what a physician drew than what another physician would draw. And the reason why we're presenting it this way, because there's always variability in between observers, in between for radiation oncologists drawing a tumor. You will never be able to do exactly what one radiation oncologist does. You take another one, it will be different. But what we would like to do is provide you with something that will be within the error in between observers. So if you had 2 or 3 observers drawing the same thing, what we will provide you for machine learning will be within that. That's the idea. And I hope that makes sense. If there are any questions, please don't hesitate to either voice them or put them in the chat, and I will look at them. So to start this, we collected 70 patients. In this case, some from our own clinic where we are funded to do some of these studies, and some from a public data set that is available from McGill. In all cases, what we're looking at are patients who have soft tissue sarcomas, who are having a CT, MR, and PET, and we are doing 3 contours. So every physician is doing 3 contours, and we have 4 physicians. So 12 contours per slice per tumor. And that may sound like a lot, but that's how we can capture variability in between readers, to look at inter-observer and inter-observer variability and see if our system is doing better than that or not. So here's an example of what the contour variability looks like. So these are the red shades are 1 reader, the blue shades are 1 reader, and then the green shades are 1 reader, and the yellow shades are 1 reader. So you see, the yellows are together, the greens are somewhat together, some are not. The blue are quite variable in this case. 1 is here, 1 is here. But those are the same physician in this slice. In this slice, it's a lot more concurrent, and that depends on 1, the anatomy, 2, where a physician is calling a line, a separation or not. And so that gives you a sense of the variability of the observers. And again, that's an important point, because you may have a 1 millimeter accuracy of delivery of the beam, but this is definitely more than 1 millimeter. All right, so the learning strategy here is to predict the GTV contours from the CT and to learn the variability. What we mean by that is, instead of saying, here's the image, CT or PET, and here's what the contour is, we're gonna say, here's what the image is, and here are what the family of contours are. And the area that everybody contours has a high confidence, the area that not everybody contours has lower confidence. So you're not gonna give in output a contour, you're gonna give a confidence on a contour, and you could threshold that to whatever contour you want. So maybe that's more clear on this image here. So we're going to determine a confidence level. Here's, for example, the target image where we have multiple readers who have contoured the same thing, right? And then you see this area, everybody contoured here. So this, we're absolutely sure this is tumor. This is probably 80% chance there's tumor. This is maybe 70% chance there's tumor. So you see it here. This is the highest, absolutely everybody in agreement, less, and then the even less, less agreement. And that's what our label is. That's what we got to learn. And that's going to be in every slice, in every patient. The network used is a UNET, where the attention gate to focus training on relevant regions. So we're going to go first into simplifying and then reproducing the whole output. And these are 2.5D networks, meaning there's a 5 input slices. It's not one slice, it's 5 slices, but it's not the whole volume. And then that is used to predict one slice output. And we're using the ordinal cross entropy loss. So here's an example of comparisons where I'm showing you in blue what the deep learning neural network is providing, and in red and orange and yellow, the different physician radiation oncologist contours, and you see clearly that we are within the variability in between observers for all patients. This is our reference, and this is what we're predicting. And you can see that in all cases, we're in very, very close agreement in between what we decide, what we predict as the tumor and what was agreed on. The blue is the consensus here. So that means like when you put all the physicians together and say, you're gonna have to agree on something. And then that's the consensus from the network. In color is what we're predicting in terms of certainty. And this is the variability in between the observers. So you see that these are very comparable in terms of performance. And if we quantify that, looking, for example, at the accuracy, you see that in terms of accuracy, which is the more important metric we will look at, the inter-observer variability comprises the variability in the proposed network. So that's usually what you hope to see, is that there's no significant difference in the mean, but also that the variance of one is including the other. So that's in terms of accuracy. In terms of sensitivity, again, there's a clear overlap, no significant difference. And in terms of specificity, it's virtually the same. So, so as a summary for this part, I hope I convinced you that yes, we can predict the gross target volume with confidence. We can tell where tumor is if we lose PET and MR. We can tell after treatment if there is remaining tumor, and we can help with delineating this in a reproducible and robust way that would make it a lot easier for radiation oncologists to do this on a clinical routine. The second part of my talk is going to be now on okay, now we know where the tumor is. How can we now deliver the dose to that tumor, especially when we're talking about a proton therapy, and how can we monitor that we have delivered to where we think we did? So what we're talking about now is we have a gross target volume, we have a clinical target volume, we know where to treat, we have a treatment plan. What we would like to see, and this is specific to proton therapy, because that was the request, how can I tell in vivo where have I delivered the dose to where I think I wanted to deliver it? So the proton range in proton therapy is a unique feature that is a blessing and a curse. It's a blessing because of the Bragg peak. So you have a very localized dose with a low entrance dose. The dose delivered anywhere other than at the end of range where the tumor is minimal. So that's great. But it's also a curse because if you have any uncertainty on the range, now you're going to be delivering a high dose to an organ at risk that may be right there behind that range fall. So here's what I mean. If this is your beam, this is your tumor, if your end of range is exactly here, you're good. But if you have a very small error in the range uncertainty, that's going to translate into a very high dose here on the peak fall-off, which would be literally in the organ at risk, the critical structure. So that's the curse. And as a result, what we do is we avoid doing this, and we try to do, different angles of beams. But that's kind of define the purpose of protons. We are supposed to know exactly where to stop and exactly what to treat. So the question is there a way we could use imaging again to tell us how well did we do on a treatment? Because for proton treatments, we never treat the patient only once. What we would do is the patient will be coming every day or every other day for 30 days, and those will be delivered every time, so that we can hit all tumors in the G cycle as they're getting into their growth cycle. So if there was any error, it's not a problem. If we know it on one treatment plan, we can correct it for the next one. That's not a big issue, but we need to know that. So here's the effect of density change on proton photons, just to give you a sense of how that affects us. And you can see here that the effect is much bigger on protons than on photons, as you can see from the bleed, as opposed to with photons. And the sources of range uncertainty are many. I'm not going to go into detail here because that's not the aim of our talk today, but there are some that have to do with the CT calibration, imaging calibration and conversion. Some have to do with the measurement of uncertainty in water and the compensator design. Some have to do with the fact that we're using the Hounsfield units, but that's not what we need. What we would need is the Z effective to know the exact range. So there are many issues with the imaging aids. And there have been many approaches trying to figure out did we deliver the dose? Because when it comes to protons with a 1 millimeter accuracy, you want to make sure that you've delivered the right dose to the right place. So there have been approaches with looking at prompt gammas. There have been some looking at from excited nuclei, some checking after treatment with MRI scans. This is the treatment is completed here. You cannot improve upon it. It's not going to give you a feedback loop to change. The prompt gammas is during radiation, but there's a lot of background and very high energy photons. It's still in development, but it's very promising. And one that we had worked on quite a bit until recently has been PET imaging of proton-induced positron activity. And the idea here is that, and we'll see that in the next slide, the idea is that we're going to use PET, that we're going to use the patient as their own cyclotron. During proton treatment, they are going to become radioactive. We are going to image the radioactivity created by the beam to determine where it was the dose delivered, because that will tell us in vivo right there, did we deliver the right dose? We're going to even do more than that. I'll show you an example of what we have developed in terms of pharmacokinetics that tell us whether the washout is changing or not, so whether tumor vascularity is changing or not with the treatment, which is a very good prognostic indicator of whether or not the tumor vascularity is being disrupted or not. So the basic idea is the following. We're going to have a proton beam coming on, say, an O16 nucleus, and then what you're going to create is you're going to have emissions from the PN reaction that is going to create N13 ammonia or O15 water. Those are the two main ones we'll see, or some phosphorus. So can we image those O15 and N13 as we are treating? And the answer is yes. So here's what you would have, the proton irradiation, and then and here's what the PET signal would be created right after irradiation due to the interaction, electromagnetic interactions of the dose in the brain. One point to remember is that the dose and the activity you measure on PET are not the same, meaning that what we are delivering is a dose. What we're looking at on PET is the activity that was caused by that dose, but that's not the same. So if you look here, what I'm showing is, for example, the range for different energies, and you see that there is a unique correlation between dose and activity range. They're not identical, but there's a correlation between those two at every energy. So we're going to use that in order to be able to go back from the image of dose on PET, from the image on PET to the dose that was delivered with a proton signal. There are a lot of challenges with these approaches. The first is that there's not much activity. We're looking at, when I say we're going to use the patient as their own cyclotron, yes, but with 1,000,000 fold less activity. There's a very, very small amount of activity compared to when we inject activity in the patient. Two, these are very short. Usually it's 0.15, so 2 minutes, and 13 or C11, 20 minutes. So that doesn't give you a lot of time after treatment to image. So you're going to have a scanner either in the room or in beam, meaning, are you going to be scanning right as you're treating, in which case you're going to have a lot of neutrons into your scanner, or right after you're done treating, you can do imaging in the same room or a different configuration in the room, and then you won't lose too much time, but you would have a cheaper solution, because now you can have a separate scanner that does that. And one thing you're going to have to be careful with is the washout, because the biological washout is something that for the longest time was empirically assumed to be a sum of exponentials, but it's not necessarily true, especially in the brain. The loss in the brain is much faster than loss in the bone. And we'll need to do Monte Carlo simulation to link the two. So we'll get to that in a minute. So what we do here is we simulate the proton treatment with TOPAZ. This is something that was developed based on Jean and developed by Harold Paganelli's group here at MGH, with whom we work, we collaborate. And that allows you to simulate the passage of the particles, the protons, through the material, through the soft tissues or bone or any of the components of the patients. And then you can simulate the full beam line, all the compensators, the anatomy in the patient, and then you calculate the dose into each voxel. Then for the PET side, we can calculate the PET signal by looking at the likelihood of nuclear reaction to produce the isotope. I'm not going to show you the biological washout applied empirically. I'm going to show you how we calculate it ourselves. We'll get to that in a minute. I think that's a much more interesting approach than taking what is being done with exponentials. So here's how we've implemented that in our system. Here's the proton nozzle. Here's an in-room PET where we have a mobile PET that we have worked with Diagnostics to develop and to commercialize so that it's available. They commercialize, we don't. That is in the room, and then the patient is going to be treated and then rotated into being scanned right away afterwards. And now we have an image on PET that we can compare to the simulated PET from the Monte Carlo simulation, where we simulated the beam delivery, generated the different radionuclides, and generated an image, and we can compare those two. This is a schematic of how we do that. So you can see here the proton beam treating the patient, and then immediately afterwards, so within a minute, the bed is rotated, and then we go into PET for imaging. And that's an illustration of in one case of how this is done. So the delay is about 2 minutes, I would say, because even though it's just a bed rotating, you have to check that the patient's okay, that they're okay, ready to rotate, that you go into the next, and then you start your scanner, and then you get them in and you start imaging. But it's definitely a lot better than getting the patient to get up, walk across to a scanner that is in another room, even if it's in the same department, and then lay down and then image again, because you've used a lot more time, and then it's impossible to perfectly register those two. Here, the patient hasn't moved at all, so we can perfectly register the treatment plan and the image from the PET at the same time. And here's an example of one of those. We have 2 beams, and we're going to image after every beam. So treatment, imaging, come back, treatment, imaging. And you can see here the PET image that was measured in vivo and the Monte Carlo simulation, which obviously are not identical, because here you're not taking into account the correct washout nor the exact activity. Okay, and then here's another example. Here's with first scan and then second scan. And here's another patient, same thing. Just to give you a sense of how reproducible this is with 2 scans, and pretty comparable. The last piece I want to show you here is instead what we do in terms of washout. So instead of this empirical values used for washout, there are decaying decaying exponentials, we decided to go with a full kinetic model for that is patient specific. And the idea is very simple. If you think about it, what we do usually in PET is we inject a dose, so it's a bolus, and then that bolus disperses into the body, say into the brain, according to the kinetics that are governed by the different tissues and the receptors in the brain. Well, here it's a little bit the same thing, except that instead of having a bolus that is distributing, you're delivering the activity to one location in the brain. That's where the proton beam is hitting. And then from that area that is dispersing according to the same pharmacokinetics of the brain in terms of perfusion, diffusion, and how the activity is taken away from that location into the blood vessels and then washed out everywhere. So we're going to model that. And the way we're going to do that is we're going to try to model the water washout, because that's the fastest and the biggest signal you'll get in the beginning. That's also the one we know how to do the easiest. So here's an example to show you the difference in washout when you do a Monte Carlo simulation with a generic washout versus what we measure from PET, and there's a clear difference that is due to the in vivo variability. So we're gonna take that into account in our signal. And the way we're gonna do that is tracking the loss dispersion of the radiotracer, as I said earlier. So if there was no decay, when I create my radiation, I'm gonna have a buildup, and then that would be there. And then because of the radiological decay, when I treat, I'll have a buildup of radioactivity, and then it will decay. And because of the biological decay, I'm going to have a further decay. And that's what I'm interested in, the difference between this and this. I know what this is. I can model it for every radioisotope. And what I would like is, by measuring this one, to get the biological one, which is this minus this. All right, so the way we do it is with a simple kinetic model, where we decide that the change in concentration over time is actually the rate of creation. That's what we create at the Big Bang when we deliver the dose. And then we lose from that, well, the Kr and Kb, which are the biological clearance and the radioactive decay, those two components of the concentration. So a very simple kinetic model. And it's exactly accurate exactly true for O15, because in that case, there's the perfect one compartment model washout. So and then it departs slightly from that for the other one. So we can model for O15, and then from that go to the carbon and then N13. All right, so ideally you would have this in the beam, because then you would have that R0, which is this point here. You would exactly have that point if you're in beam. If you're in room, you're rotating, going in 2 minutes later, now you're here, somewhere here. So you've lost some of that, but it's still feasible. You're not at 6 minutes. You see, if you're 6 or 8 minutes, all of the signal is gone. But at 2 minutes, it's still feasible to have this curve and go back from that to go back in time to rebuild this point, which is what we want, which is the R0. So this is exactly what we'll do. So instead of doing a treatment plan, do a Monte Carlo simulation, try to match that with what we image on PET and try to compare the two, what we do here is we have a treatment plan, we do a Monte Carlo simulation to with the production map, and then we compare that directly to the estimated production map from kinetic modeling through our kinetic model that we just described. And here's an example of what that looks like. So this is in a rabbit, and what we did here is we had the live rabbit and then dead rabbit. So the only difference in between the two is the biological washout, because between the two there is no more biological washout, but the radioactive decay is the same. So we repeat exactly the same experiment first while the animal is alive, and then after the animal is sacrificed, we will do the same treatment again, and the difference between the two is what gives us the exact washout. We will calculate that washout again from the live animal, and we'll show that what we estimate is exactly the difference between the two, which is what we're looking to calculate. And the ratio of the rates was about 1, so no statistical significance there. So that's very encouraging. Here's now some examples from patient studies where now we're looking at the difference in the loss of activity. Look at the difference between the skull and the brain. There's very little washout in the brain, in the skull, sorry, because very little perfusion, a lot more in the brain. So you can see the difference in activity loss. And if you look at the time behavior, let's say in this area, you'll see that here's what the activity looks like in the bone, here's what it looks like in the brain, and this is the biological washout because both of those are the same radio tracer. So from that, again, we can calculate the R's and the K's and then determine what the biological washout is. This is to show you finally, my last slide, that now we can be very reproducible. These are 3 scans of the same patient done at 3 different times, where you see that there's excellent correlation between the 3, a very good agreement once we've modeled the biological washout, because we're capturing now what the biology is as we're treating the patient. So this is very encouraging because that means that, yes, not only you can tell whether you treated the right location, but also whether or not you're changing your washout over time as you're hopefully disrupting the tumor vessel bed and angiogenesis. All right, so this concludes my talk. With this, I would like to maybe give you back the screen and thank you again, and take any questions you may have. I didn't see any in the chat, but there may be some in person.
Thank you so much, George. That's really wonderful work. Thanks for telling us about what you're doing in proton therapy and algorithms. You're connecting all the pieces in ways I certainly didn't know about. So with that, we'll take any questions that you've got from the audience. You're welcome to use your camera, use your microphone, or put them in the chat. Don't be shy. So there's a question, may you comment on the selection of the UNet architecture?
So for this particular case, we went with a simple UNet because now there are better, probably better networks, although we don't think the outcome is going to be that different. The reason was because this was a very standard problem where we had in input a large input, which is the image, and we had in output also a large input, which was the pattern. So that's why we went with the UNet. But I agree that there can be other architectures that can be refined for that, and we're happy if anybody wants to try any of those. We're happy to work with you on those. And I didn't forget the question that was brought up. I realize now that I didn't show this, but the question was beforehand, one of the questions beforehand was, well, in brain tumors, how do you know after treatment if when you see something, is that still tumor or not on MR? Because on MR, it's very hard to tell. And I had one example, maybe I'll show you just that one, so that, because I picked that up on purpose to for that very question. So here's an example of one of those that you're asking about, where you can see that here's this is after treatment. This is a choroid carcinoma, and after treatment on MR, it's a battlefield. It's impossible to tell on MR after treatment if there is residual tumor. It's very good pre-treatment. MR is excellent pre-treatment to tell you where the tumor is. After treatment, it's almost impossible. One option for you is PET. And that doesn't have to, in this case, it's FDG, because this area is an area there shouldn't be activity because you've treated it, but I'll show you another example with another tracer in a minute. And you can see that there is actually residual activity here. And when the patient was followed over time, that turned out to be a subendymal nodule. But this is not the only thing you can do. There are many other things you can do here. Here's the area that has grown over time. This was 3 months later. Methionine, or if you don't have C11 methionine, you could look at FLT, is another option. Here's an example of one of those where you can look on the FDG. There's very little sign after treatment if there's been, if there's still any tumor remaining or not, and the T1 GAD doesn't give you much. And if you look at the methionine, you can see clearly that there's still remaining tumor here. So PET is a very viable option in this case for looking at either areas where you don't see much on MR, or after treatment, areas where you can see anything on MR, whether there's a remaining tumor or not. MR spectroscopy is one where I understand from your comment that people are not very keen on that. I understand that because looking at one voxel is hard, but that has to be revisited with MR spectroscopy imaging, because we literally have we have some of our investigators are now looking at doing basically an image of the entire brain in I think I can show you one here. The entire brain in less than 6 minutes, and that's an MR spectroscopy image, not a pixel. So that changes a lot of the considerations, because I agree with your physicians that if it is to if I need to tell you where to look, well, I don't know where to look. But if I give you a spectroscopy image of the entire brain in a 3 millimeter resolution or 2 millimeter by 2 millimeter in 8 minutes, now we're talking, and you have choline creatine everywhere. So this is definitely an option that is becoming more realistic, but I understand your point on that.
Professor Bowling, do you have any follow-up on that question? I see you're here with us.
No, I just, sorry, I had to step out at the very beginning. We're doing a simulation, but I appreciate the insight. And yeah, it's just an area that we struggle with. And we've read about PET, we haven't employed it yet, but it seems like that might be the method. I mean, one of our rad oncs here terms it the bane of his existence. We treat these people and we follow them, and is it treatment effect, radionecrosis, or tumor progression? And it's something we really struggle with. So appreciate the insight.
Right. The only challenge you have with those is, but I think you have a good radiochemistry team. You need to have somebody who's able to make the methionine for you or the FET for you, because these are not standard isotopes, but they are definitely produced and feasible. So
I don't see any questions in the chat. I thought it was a very creative way that you found ground truth. I hadn't seen it before, at least. So I guess I was wondering about, after taking out the tumor very quickly and freezing it, you're cutting off the vasculature. I don't know if the freezing changes anything. Do you think there could be much of a difference between the actual in vivo and what you have after cutting it out and freezing?
No, because actually this is this is the standard that is being done. When you're looking at on pathology, we're not everything is kind of fixed, and what you're looking at, the cells are there, so that there's no impact there. Freezing is much better than other options for preserving tissue, like formaldehyde, because there you start, for example, for brains who are preserved in formaldehyde instead of frozen, there you start affecting some of the proteins that break down. But I don't think that's the case with freezing. It's the safest to the brain, the least invasive, or to the muscle, the least invasive way of saving it.
Thank you. I also saw that your physicians were using the 3 different modalities, I think, to draw the tumor volume. And then you were, kind of using all of them to gain information, if I understood correctly. Does it make sense to weight physicians that have more experience, maybe more experience than a resident? Is that something you've thought about?
Yes. So in the paper we're submitting on this, we decided not to do that. Because we realized that, so we thought initially that the most experienced radiation oncologist would do the best performance. And that was true in the when they first are engaged with the drawings. As they go into drawing number 10, they tend to be less attentive than the fellow whose life depends on doing this right. Otherwise, they're gonna have the wrath of the attending. So it's not a given that it's always that way, but that's what gave us the idea for providing this more as, so this is not at all meant to be, look, this is what is going to replace the radiation oncologist next year. Buy 2 of those and you would save on 1 radiation oncologist. Not at all. The idea here is more, you save a lot of time because you have something that is very close to what you need. And all you have to do is just tinker, change it a little bit. if you're an expert. And if you're not an expert, which is the case in a lot of places, a lot of countries in Europe, for example, you don't have a sarcoma radiation oncologist and a brain tumor radiation oncologist, and it's a radiation oncologist that draws everything. If you don't see a lot of those and you're wondering, okay, so where do I drop the line? That will give you a good place to start, and then your anatomy kicks in and say, okay, well, I should not include this, or I should change this. It is meant to, in a way, and that's the next study we're doing right now, is we're trying to measure how much time do you save but it's a hard one to do, because now we have to have observers who have never seen these. We can't use the ones who've done it. We have to use new ones who have not been corrupted by knowing what it is, and ask them, okay, draw this, and then see how much time it takes, and then let them forget about it, and then draw it again with the neural network and see if it's faster. You know what I'm saying, to say it again, because the difficulty with this experiment is they always remember, once they've seen one treatment, they always remember that the next time they see that same treatment, and they go faster. So it would be unfair. But,
That's very interesting. So we have a medical physics student that's wondering about the high energy photon application for PET, and whether that's really still of interest, or if it's really just more proton therapy that's of interest with PET.
Yeah, so it depends what we're talking about. The in-room dose verification, that's for proton or carbon, because you have to create a positron signal. But for the first part I showed is actually what was for radiation therapy, mostly photon, not necessarily proton. So the imaging piece of where the tumor is, that is not at all limited to proton. Yes, you can do that with photon as well. That's correct.
Great, thank you. Are there any other questions that anybody in the audience would like to ask verbally? Okay, if not, thanks so much for your time. We really appreciate it. I was really interested to learn about what you're doing there, and as it relates to PET, which I'm interested in, as it relates to proton therapy, which is ramping up in the area. Thanks so much again. So.
It's great seeing you all virtually, and hopefully one day we'll see you in person. And if any interest in any of those, let us know. Thank you for inviting me.
Okay.
Take care, everybody, and stay well.
All right. Bye, George.